Hello everyone, welcome to another episode of Clinical Case Discussion. This is episode 4 of groin swelling. So let's continue with the discussion part today. So the first one is we need to understand inguinal hernia classification. Before we go there, you know that inguinal canal is nothing but a upper musculo-aponeurotic canal present between deep ring and superficial ring. So if you understand that basic anatomy point, so you know that this is the deep ring and this is the inguinal canal, this is the superficial ring. I told you, when do we call a hernia as an indirect hernia? When it is coming through it is entering into the inguinal canal through the deep ring and it is traveling through the inguinal canal, then exiting through the superficial inguinal ring. This is called indirect hernia. When do we call a direct hernia? It is directly coming from the posterior wall and exiting through the superficial inguinal ring. So, if we understand this basic point, we can understand the classification. So, the first one is indirect inguinal hernia. Second one is direct inguinal hernia. Sorry, direct inguinal hernia. Again, in indirect inguinal hernia, usually this direct inguinal hernia is confined to the inguinal canal, almost never descends down into the scrotum. This is mainly because of the posterior wall weakness. Whereas this indirect inguinal hernia, again, this can be of two types. So the first one is complete hernia, means let's say for example this is the deep ring and inguinal canal and this is the superficial ring. The hernia can descend down till the bottom of the scrotum. Okay, so this is nothing but, that is why this is called complete hernia. So it is till bottom of the scrotum. Next, another one is incomplete hernia, where it can confine whether to the inguinal canal or it can descend just in the superior aspect of the scrotum. So I'll just write down here. So it can be again two types, where the first one is called bubonosyl and the second one is called funicular hernia. Okay, so what is the basic difference between bubonosyl and this funicular hernia is that, so please understand, this is the inguinal canal. The hernia will be confined to the inguinal canal like this. Whereas in funicular hernia, so if you take, this is the scrotum you have, so the hernia will occur just into the superior aspect of the hernia, I mean just into the superior aspect of the scrotum like this. Okay, it is not coming till the bottom of the scrotum, but still it is present. It has just entered into the scrotum. So this is the difference between bubonosyl and funicular hernia. Okay, right. So this is the basic classification of inguinal hernia we need to understand. Now moving to the next one. So there are certain named classifications which will be asked by the examiner. These are more important for postgraduates, but undergrads can be asked about the names of the classifications. So I'll just try to make it easy how to remember the classifications easily. The first one is NIHAS classification. So where is NIHAS maneuver encountered? So please understand there is another NIHAS which is NIHAS maneuver. We have seen this NIHAS maneuver in thyroid surgery. Please go and watch thyroid surgery part video where the superior lobe of the thyroid gland is gently pulled down and out to expose the space of Reeves to visualize the external branch of superior laryngeal nerve. That is called NIHAS maneuver. This is NIHAS classification. Okay, so there are four types of classification, like four entities here in the NIHAS classification. So the first one is type 1 is both type 1 and type 2 are indirect hernia. So you can simply remember this is the deep ring, inguinal canal, superficial inguinal. So the first one is related to type 1 and type 2 are related to both indirect hernia with related to the status of deep ring. So deep ring is normal in case of type 1 whereas it is dilated in type 2. Okay. So just when you come medial aspect, this is the type 3 where you are having posterior wall defect. So you can remember again it is of three types. 3A is direct hernia, 3B is pantaloon hernia which is also called dual hernia, nothing but both direct and indirect hernia. Then 3C is your femoral hernia. Okay. Now, coming to type 4, all recurrent types of hernia will come under type 4. So, 4A is direct, 4B is indirect, 4C is femoral, 4D is combined. So, recurrent direct hernia, recurrent indirect hernia, recurrent femoral hernia, recurrent combined hernia. So, this is about Nahes classification. Now, moving to the next one, which is called Gilbert classification. So, here we have 7 types. So please understand, you can easily remember Gilbert. The word Gilbert has got 4 letters. So you can remember it is of 7 types. Again, type 1 and 2 and 3 are indirect hernias, whereas type 4 and 5 are direct hernias. And 6 is dual hernia. Last one is femoral hernia. You can remember this 5, 6, 7 or 4, 5, 6, 7 is something like a DDF. So it is nothing but direct, dual, femoral. Okay, so this is 4, 5, 6, 7. So again in 1, 2, 3, based on how much is the defect. If it is small, type 1, medium, type 2, large, type 3. So this is about Gilbert classification. Now coming to EHS classification, which is European Hernia Society. There are certain classifications. EHS classification for inguinal hernia, EHS classification for ventral hernia is different. So here they are mentioning whether it is primary or recurrent, and whether it is lateral or medial. It is nothing but, if it is a direct hernia, it is called medial hernia. If it is something from the deep ring or indirect hernia, is lateral hernia. So what is the size of the defect? Based on that, like how many fingers are being admitted into the defect, based on that one finger is given as 1.5 centimeters. So let's say for example, you have got a patient who is having indirect inguinal hernia with a 3 centimeter defect, which is of primary hernia. So you can mention like that. So P primary, indirect means lateral. So L, 3 centimeter means 2 fingers. So you can write down 2 fingers. So this is how you can categorize the types of hernia according to the EHS classification. So it is a very easy technique. Whenever you get a hernia case in the ward, if you try to habituate to write down the type of hernia according to the 3 classifications, we can revise the classifications and we can remember them easily. Okay, right, next. So what is the basic differential diagnosis of a groin swelling? So whenever a groin swelling is there, it is not always hernia. There are many other conditions which can present as groin swelling. So we can remember this differential diagnosis easily with the help of inguinal canal. You can remember like in the front of inguinal canal or beside inguinal canal, within the inguinal canal and behind the inguinal canal. So what are the common entities you can have in the front of inguinal canal or beside the inguinal canal is that your basic skin and subcutaneous tissue swelling. So one is lipoma, then sebaceous cyst. Rarely you can get neurofibroma, right? So also just inferior to the inguinal canal, you have got inguinal lymph nodes, superficial inguinal lymph nodes. Also, they are present behind the inguinal canal. So you can write down here even inguinal lymphadenopathy. That is also one of the common conditions. Now, present within the inguinal canal. To understand this, you need to understand what are the contents of inguinal canal. So you know that one is cord structures and another one is ilioinguinal nerve. So in females, it is round ligament of uterus and ilioinguinal nerve. So within the inguinal canal, during the embryogenic testis descent of the testis, this testis can be arrested somewhere in the inguinal canal or just adjacent to the inguinal canal. So the common quantities you will come across is one is inguinal hernia. Also, just adjacent to that, you can get femoral hernia, or you can have undescended testis, UDT, or ectopic testis, or rarely you can have lipoma of the cord, spermatic cord. Then also you can also have encysted hydrocele of the cord. Okay, so what else? Inguinal hernia, femoral hernia, undescended testis, ectopic testis, lipoma of the cord, encysted hydrocele of the cord. So at this junction, the examiner can ask you one important question: how can you differentiate between encysted hydrocele of the cord and the inguinal hernia? There is an important test called traction test. traction test, where you will gently hold the testis, ipsilateral testis of the patient, and you will just give a gentle traction. If you see that the swelling is also moving down when you are gently pulling the testis down, it means that it is connected to the spermatic cord. So the diagnosis would be encysted hydrocele of the cord. Okay, so these are the common conditions within the inguinal canal you can have. Now coming to behind the inguinal canal, just remember the anatomical structures: vessel, muscle, nerve, and lymph nodes. So the vessel is external iliac artery aneurysm or femoral artery aneurysm. Both are possible. Muscle is psoas muscle. This is nothing but your cold axis of psoas major muscle. So in case of immunocompromised patients, we encounter this commonly. Then very rarely you can get nerve tumor. Then lymph nodes is nothing but your inguinal lymph node enlargement. So these are the common conditions you can have in the groin region, which can present as a groin swelling. So these are the differential diagnosis of a groin swelling. Okay, right. So we'll just look at a few important questions in the discussion part. It is must and it is must to learn the definition of hernia. I have discussed this in the first episode of groin swelling. So hernia is defined as an abnormal protrusion of a whole or a part of viscous through a normal or an abnormal opening in the wall that contains it. Okay. So coming to the parts of hernia, you know that basically hernia occurs through a sac. So this is nothing but your sac. So within the sac, you will be getting your content. This content can be either bowel or omentum. Commonly we encounter these two. They can be others also. Then you have coverings. Okay, so this is nothing but your coverings, right? Next, so what are the common coverings of hernia? Again, this depends on whether it is an indirect inguinal hernia or direct inguinal hernia. So I'll just show you this here. So this is your external oblique, this is your internal oblique, this is your transverse abdominis, this is your fascia transversal. So please understand, whenever there is a indirect inguinal hernia, you know that the deep ring is a defect in fascia transversalis, and this superficial inguinal ring is a defect in external oblique aponeurosis. So whenever there is indirect inguinal hernia is happening through the sac, it will take all the layers that are present between the deep ring and the superficial inguinal ring. So you can remember the coverings of the indirect inguinal hernia is nothing but external oblique. This external oblique will give rise to something called, so you can remember, this external oblique will give rise to something called external spermatic fascia, right? Next, internal oblique will give rise to something called cremasteric fascia or cremasteric muscle. Then this transverse abdominis, the name itself says it is confined to the abdomen. So transverse abdominis will not give rise to anything. Then fascia transversalis will give rise to something called internal spermatic fascia. Internal spermatic fascia. Okay, so fascia transverse will give rise to internal spermatic fascia. So these are the important coverings of the indirect inguinal hernia. Now, if you come to direct inguinal hernia, please understand it is directly occurring through the posterior wall because of the weakness. So here also in the medial aspect of the inguinal canal, this internal oblique and transverse abdominis is fused together to form a single structure called conjoint tendon. So you can remember the layers of direct inguinal hernia or coverings. So one is external oblique, second one is conjoint tendon, third one is fascia transversalis. So these are the important coverings of the direct inguinal hernia, right? So now let's say for example you have told the provisional diagnosis is right-sided, indirect, complete, reducible inguinal hernia. So the examiner will try to ask the questions with reference to each word in the provisional diagnosis. So let's say for example you have told right side. So the question will be, which side is more common for inguinoscrotal pathologies and why? The answer is right side. Why means because the right testis descends little later than left testis. So right testis descends later than left. And why is it significant? Because whenever the right testis is descending little bit later, right side processus vaginalis will be patent for more time. That is why there is more chance of getting inguinal scrotal pathology on right side. So why is it important? Means it is related to your processus vaginalis. Okay, right. Next. So you have finished which side. Now coming to indirect and direct, we will see what are the differences between direct and indirect hernia in the subsequent slide. Okay, what is complete hernia? Just now we have seen in the classification. And now coming to reducible and irreducible, I'll come to the complications here. So you have told it is an inguinal hernia. So the question will be how or why do you say it is hernia? Or the question can be what are the cardinal features of hernia? Or the examiner can also ask you like this, how do you justify it is a hernia? All the four questions, the answer is same. So the first one you need to tell is anatomical location of swelling within the hernial sites. Within the hernial site, nothing but your inguinal region. Second one is reducibility present. This is the order in which you have to answer the question. We should not change the even order of the answers. Okay, right. The last one is expansal cough impulse. So these are the three cardinal features of a hernia, right? So we will see one by one how the questions can be asked again from these 3 points. Okay, so each one is again a question. So what are the different hernial sites? You said it is an anatomical location is present within the hernial site. So you can understand these hernial sites with a simple classification. So one is internal hernias, another one is external hernias. Okay, so again in internal hernias, both for internal and external, you can remember from top to bottom. So first one is internal hernia, cerebellar herniation through foramen magnum. So you know that whenever there is raised intracranial pressure, there will be coning that is happening. So the cerebellum can herniate through the foramen magnum. That is one of the examples for your internal hernia. Now coming to your hiatus hernia. Also congenital diaphragmatic hernia. This can be again anteromedially you will be having Morgagni hernia, whereas posterolaterally you will be having Bogdalak hernia. Okay. Now there is something called paraduodenal hernia. Then there can be Stammer's hernia. These are the post-operative scenario hernia, Stammer's and Peterson hernia. I'll explain this in subsequent slide with the help of a diagram. So there is another thing called herniation into band of Lade, band of Lad, sorry, band of Lad. There is something called Lad's band. Hernia can occur into that Lad's band. Then last one is your obturator hernia. These are the examples for internal hernias. Coming to external hernias, rarely you can get a hernia of lung in case of pediatric people where the chest wall is weak. So hernia of lung. Then just the classical ones, which is nothing but your epigastric hernia. So you can remember with the help of a diagram. So this is your epigastric hernia, umbilical hernia, then paraumbilical hernia. If a hernia occurs through previous incision, that is called incisional hernia. Then laterally you can have lumbar hernia on the lumbar triangle. Then is your inguinal hernia. Just below that is your femoral hernia. So these are the examples for your external hernias. There is another thing called spigillin hernia. I'll explain that in subsequent slides in the named hernias. Okay. So spigillin hernia is also an example for external hernia. So these are the different examples for different hernial sites. So the first sentence is answered. So you told the anatomical location of swelling is present within the hernial site. The examiner will ask you what are the different hernial sites. Okay. Now the second point you told you that there is reducibility. Uh, I mean, there is reducibility present. So the examiner will ask you what is the difference between compressibility versus reducibility. So please understand, let's say for example you have a swelling, a groin swelling like that, you have tried to manipulate it gently and you have reduced the swelling. So it will not reappear on its own unless you have a precipitating factor. So you are asking the patient to cough. So this cough is acting as a precipitating factor. Then again it will reappear. So you can differentiate it with something like the entire swelling can be reduced, entire swelling disappears or decreases in size, and also there should be some secondary precipitating factor should be there. Precipitating factor should be present for the swelling to reappear. For the swelling to reappear, there should be some secondary precipitating factor. Whereas compressibility, let's say for example, you have got a some swelling present arising from a vessel. It can be blood vessel or lymphatic vessel. So you have tried to reduce it, but it doesn't reduce completely. So doesn't reduce completely. And also the moment you release the pressure, it will reappear immediately. Reappears immediately after the pressure is taken, after pressure is released. So the example is hemangioma or lymphangioma. Hemangioma or lymphangioma. So the reducibility example is hernia. So this can be cough or Valsalva maneuver. All these are secondary precipitating factors. So there should be some secondary precipitating factor for the swelling to reappear, that is called reducibility. Whereas, and also here you don't need any secondary precipitating factor. Just the moment you release the pressure, it will reappear. That is called compressibility. Okay, right. So we have answered the second question now, reducibility versus compressibility. Now coming to the third point, expansal cough impulse. So here the examiner will ask you, what are the different swellings in the body which will give positive cough impulse? You should answer the question with a sentence. Not, you should not give examples directly. Okay? To impress the examiner, you should tell this sentence. Those swellings which are in communication with potential body cavity spaces. This word should be there. Then the examiner will get impressed. Potential body cavity spaces. So, which swellings will give positive cough impulse means those swellings which are in communication with potential body cavity spaces will give the positive cough impulse. Now, the examiner will ask you, what are the potential body cavity spaces we have in our body? So, the first one is cranial and spinal cavity, then thoracic cavity, last one is abdominal cavity. Okay, so the examiner will ask you what are the examples for cranial and spinal cavity. So here you get something called myelocele or myelomeningocele, or even this is the difference between meningocele and myelomeningocele. Sorry, this is not myelocele, meningocele. Meningocele, myelomeningocele. So myelo is nothing but your spinal cord. So meninges means only the meninges are getting herniated. Myelo means along with the meninges, part of the spinal cord is also getting herniated. Okay. So meningocele, myelomeningocele. In the brain, you can remember encephalocele. Also, rarely you can get a dermoid cyst with the intracranial communication. Dermoid cyst with the intracranial communication. That will also give positive cough impulse. Coming to thoracic cavity, you know that whenever there is a pyothorax, it will try to escape through the path of least resistance, and it will try to expand or spread to the chest wall anteriorly. So the condition is nothing but your empyema necessitans. This is nothing but empyema thoracis getting spreaded, or it is expanding onto the anterior chest wall. That is called empyema necessitans. Now coming to the abdominal cavity, you know the classical example is hernia. So these are the examples which will give, these are the conditions which will give positive cough impulse. So what are the swellings means? Those swellings which are in communication with the potential body cavity spaces. What are the potential body cavity spaces means? Cranial cavity, thoracic cavity, abdominal cavity. And lastly, if you answer this question very well, the examiner will ask you, only if the examiner asks you, you tell these examples, otherwise not required. Are there any other swellings which will give cough impulse means? You can get laryngocele, which will give positive cough impulse test, and also there is something called Cephana varix. Cephana varix. This is nothing but your terminal dilated portion of your great saphenous vein, and very rarely you can get a varicocele. So these are the other conditions which will give cough impulse. Only if the examiner asks you, you tell these last three conditions. Otherwise, the first three examples based on that concept is sufficient. Sufficient. Okay, right. Now, so another question regarding cough impulse is that even though it is hernia, you told that expansile cough impulse is a cardinal features of hernia. But what are the scenarios, even though it is a hernia, where will you see cough impulse is absent? So the first one is when you have got a incarcerated hernia. It is nothing but your obstructed hernia where the obstruction is due to inspissated fecal material. So you know this is the deep ring and this is the superficial inguinal ring. When you have got a hernia which is of a prolonged duration at the level of deep ring, because of the adhesions or because of the tightening of the deep ring, there you can get a absent cough impulse. Also, whatever the content that is present within the hernial sac, there can be adhesions present between the content and the sac. So whenever there is adhesions present between sac and content, then also you will get a cough impulse is little bit absent. Okay, right. Next, with continuing. So what is taxis? Taxis is nothing but it is the systematic method of reducing the hernia. We are doing it clinically. So how do we do that? The patient will be lying down in supine position, hip and knee are flexed, with hip is being kept at internal rotation and adduction. So this is the position in which you will be doing taxis. You will gently hold the fundus of the hernia with your right hand, and with your left hand you will be gently guiding it to the through the superficial inguinal rib. That is called taxis. So one important clinical point we need to understand is we should never ever do forceful taxis. What happens if you do forceful taxis? It can leads to, first one is because of the force the sac can rupture. So rupture of sac. So second one is there can be extra peritonealization. It means that at the level of deep inguinal ring, because of the rupture of the sac, the contents can go extra peritoneally. Okay, that is called extra peritonealization. It can be even rupture of bowel also. Okay, and the last one is something called reduction en mass. What is the meaning of reduction en mass? So if you try to reduce it forcefully, let's say for example, if this is the deep ring and this is the superficial ring and inguinal canal, if you try to reduce the hernia forcefully, here at the level of deep ring, there may be a constriction point present. So if you try to reduce it forcefully, this constriction point entire sac will go into the peritoneal cavity with the constriction point being intact. So it will lead to gangrene of the content in the future days. So it is very dangerous. Now coming to complications of inguinal hernia, you can remember easily with the help of a mnemonic IOS. That is opposite to the Android. You can remember. So I for irreducibility, O for obstruction, S for strangulation. So I told you what is the basic difference between obstruction and strangulation. So here you have blood supply is intact, whereas it is compromised in case of compromised blood supply will be there in strangulated hernia. Now, what is incarcerated inguinal hernia? Please understand, it is nothing but a type of obstructed hernia where the obstruction is due to inspissated fecal material. Inspissated fecal material. So in case of enterosil with a prolonged duration, the fecal metal can get inspissated, and that will cause the obstruction. That is called incarcerated inguinal hernia. So what is inflamed inguinal hernia? Whenever the content of the hernia is inflamed, that is called inflamed inguinal hernia. What are the examples? You can have appendix or you can have fallopian tube. Okay, next. So these are the important named hernias we have. I have enlisted them in an alphabetical order so that we can remember them easily. So the first one is Bogdalak hernia. So I told you this is nothing but both of these are congenital diaphragmatic hernias. So Morgagni hernia is happening through anteromedial aspect or anteromedial defect, whereas Bogdalak is happening through the posterolateral defect. Okay, so this is the diaphragm we have. So anteromedially we have got Morgagni hernia, and posterolaterally you have got Bogdalak's hernia. So anteromedial is happening through the space is called space of Larry. Space of Larry. And which is more common among these two? Obviously, Bogdalak is more common. Next, dual hernia or pantaloon hernia, which is also called saddleback hernia. This is nothing but both the indirect inguinal hernia plus direct inguinal hernia are present in the same patient on the same side. And again, Gibbon hernia is nothing but he was a very famous scientist. Both the hernia and hydrocele are present on the same side. So it is called Gibbon's hernia. Now, Greenfield hernia and Petit's hernia are both of these are lumbar triangle hernias or lumbar hernias. So we have two lumbar triangles. Greenfield hernia is happening through the superior lumbar triangle, whereas Petit's hernia is happening through the inferior lumbar triangle. For PGs, it is important to remember the boundaries of these lumbar triangles. So I'll just show you in the picture. This is the inferior lumbar triangle and this is the superior lumbar triangle. The boundaries of inferior lumbar triangle are anteriorly you have got external oblique aponeurosis, external oblique muscle, and the iliac crest is forming the base, and latissimus dorsi is the lateral boundary. Whereas coming to superior lumbar triangle, you have got a 12th rib here. So that is the 12th rib superiorly. Then you have got paraspinal muscles, especially this quadratus lumborum or rectus spinae, that is medially, and internal obliques is present laterally. So these are the boundaries of lumbar triangles. Now, little or Amayan hernia. So this is nothing but when appendix is the content of inguinal hernia, that is called little or Amayan hernia. Now, for PGs, when appendix is present as a content of femoral hernia, when appendix is a part of femoral hernia, that is called Degeringiote hernia. So Degeringiote hernia. This is for PGs. Now, Litter's hernia is nothing but the content of inguinal hernia is Meckel's diverticulum. Okay, right. Next one is Meidel's hernia, which is also called W-shaped hernia. So if you have the defect like this, you have got a W shape, two loops of the bowel are present within the defect. That is called Meidel's hernia. Okay. So Peterson hernia is nothing but, I'll show you the picture. It is occurring behind the ruling. So just remember this point. Behind ruling in gastrogenostomy. Next, Richter's hernia is nothing but only a part of circumference of the bowel is herniating. Part of circumference of the bowel is herniating. Next, sliding hernia, which is also called hernia en glissade. Please understand, it is a part of extraperitoneal bowel or urinary bladder. It will descend down and it will form the part of the wall of the hernia. I'll show you the picture here. So this is the actual hernia which is happening. So you can follow the tracer. So this is the hernial sac. So the posterior wall of the hernial sac is formed by the colon here. Like that, rarely you can get urinary bladder as a part of the posterior wall of the hernia. That is called sliding hernia, which is also called hernia inglisa. Then Spigelian hernia is something that is occurring through the Spigelian point. I'll show you in the next slide. So Stammer's hernia is nothing but it is through the transverse mesocolic defect. Again, this is nothing but in gastrogenostomy only. I'll show you the picture. So this is the picture we need to understand. First I will explain what is spigelian hernia. So you know that this is the umbilicus. Between umbilicus and pubic symphysis you have an imaginary line called arcuate line, which is also called line of Douglas. So this is nothing but your rectus abdominis. This is the midline. So the junction of rectus abdominis and arcuate line, this point is called spigelian point. So this is nothing but your lateral border of rectus, which is nothing but linea semilunaris, lateral border of rectus. Okay, so this point is called spigelian point, the junction of arcuate line and lateral border of rectus. So whenever a hernia is happening through the spigelian point, that is called spigelian hernia. Now, this is something like your gastrojejunostomy, Roux-en-Y gastrojejunostomy. So you can see here behind the roux limb, this is your roux limb. Behind the roux limb, there is a potential defect that is called Peterson defect. Whenever hernia occurs through this Peterson defect, it is called Peterson hernia. And this is the retrocolic type of GJ. So retrocolic. So in the transverse mesocolon, you have a defect here. And whenever this hernia is happening through the transverse mesocolon defect, that is called Stammer's hernia. Okay, right. Now, there are two important questions the examiner will ask you. What are the differences between direct and indirect inguinal hernia? Also, what are the differences between enterosyl and omentocele? How will you differentiate between enterosyl and omentocele with the examination? So, please understand direct inguinal hernia and indirect inguinal hernia. You can remember easily inspection and examination. So, usually you will have direct inguinal hernia in elderly, whereas indirect hernia is seen in children to young adults. Then, history of spontaneous reduction will suggest that it is coming directly from the posterior wall. So it may suggest you that it is direct inguinal hernia. So in the early stages of indirect hernia also you can have spontaneous reduction or with manipulation. This may be absent in later stages of the indirect inguinal hernia. Now coming to inspection, you have the shape. It is globoidal or hemispheroidal in case of direct inguinal hernia, whereas it is pyriform shaped in case of indirect hernia. So usually it is confined to the inguinal canal, direct hernia, whereas it can descend down into the scrotum, and direct hernia usually will never descend down into the scrotum. Then as soon as the patient lies down, usually there will be spontaneous reducibility of the swelling present in direct inguinal hernia. Coming to palpation, it is easily reducible, whereas it is reducible with gentle manipulation. Again, the Siemens deep ring occlusion test is negative. What do you mean by negative? It means that you are able to see the swelling which is visible bulge seen in the medial aspect of the occlusion point. That is why the test is negative. And in Siemens three finger test, you know, the index is at deep ring, middle finger is at superficial inguinal ring, and the ring finger is at saphenous opening. So obviously in direct inguinal hernia, you will get impulse at the middle finger. Now in the finger invasion test, impulse is being felt at the pulp of the finger. So it indicates that the hernia is coming directly from the posterior wall. Now, if you apply the same NEMO test to the indirect inguinal hernia, obviously deep ring occlusion test, it is being done to rule out indirect inguinal hernia, so it will be positive. Then Siemens three finger test, you will be having the impulse being felt at the tip of the finger. So index finger at the tip. Next, finger inversion test. Sorry, in finger inversion test, you will be having the impulse is being felt at the tip of the finger, and in three finger test, you will be having impulse is felt at the index finger. Okay.